Hello, my name is Juan Lawrence and I'm a second year physician assistant student from South University in West Palm Beach. Today I'm going to be talking about how we can use cognitive behavioral therapy in the school setting to prevent future mental disorders such as anxiety and depression. Thank you for listening and hopefully this lecture can contribute to a healthier community. Okay, here is a content overview of the things that we're going to talk about. First, I'm going to introduce myself. I'm going to tell you a little bit more about me and about the profession uh, as a PA. I'm going to explain more what a PA is, a physician assistant is. Then I'm going to talk about, give a little overview of what anxiety and depression is so we can have a better understanding of the condition that cognitive behavioral therapy can treat. Then I'll continue to explain what CBT is and why is it beneficial for to use in the medical field, and then um, a plan of how we can use it to for our objective of using it as a preventive method for mental health disorder. Who am I? That's me in the picture. My name is Juan Lares and I'm a physician assistant student currently in my second year at South University in West Palm Beach. I was born in Venezuela and moved to Florida when I was a teenager. I completed my undergrad in biology at Warner University in Lake Wells, somewhere in Central Florida. Then I obtained my master in business administration at Mercy College in New York. I had the opportunity to play soccer throughout my college, which it was a great experience. And before starting PA school, I worked as a medical scribe in the emergency room. That's where I obtained my um, clinical hours required for PA school. And to those interested in the medical field, I would recommend to do medical scribing. It's a great experience that has helped me throughout PA school. I also want to take the time to thank Professor Hernandez, who was my capstone advisor. A little bit about her is that she earned her Master of Medical Science from Yale Medical School Physician Associate Program and have been practicing medicine in the ER in different places for the last 11 years. Thank you. So what is a physician assistant or PA? A PA is a medical professional that evaluates, diagnoses, and treats patients. This means we can see the patient, we can do a physical exam, we can order labs, we can make the diagnosis, prescribe medication, do the entire patient care. We work in collaboration with physicians in different settings. We can work as outpatients or inpatient, as well as being involved in surgeries and do procedures. The preparation takes about 6 years, uh, taking into consideration undergraduate and PA school. So that's the 4 years of undergraduate plus 2 years of PA school. Um, for some people, it can take more. Most of schools require or prefer some clinical experience before school, whether it is EMT, ER tech, medical assistant, medical scribe, phlebotomist, and many others positions that will expose you to patient care. For this reason, people may take some time between undergrad and PA school to be able to um, get those hours, get that experience before PA school. But many people do it during undergraduate, and once they're done with undergraduate, they can go straight into PA school, and they can basically finish in 6 years. School is basically PA school is basically broken down in two: one didactic year and one clinical year. Those time, the average I would say is it's 2 years. However, our program is 27 months, so it's a little over 2 years. For us, it's 15 months in class, didactic, and 12 more months rotating through 7 different specialties. Once we graduate, we need to take one board exam called Physician Assistant National Certifying Exam, or PANS, to be certified. After this, we need to find a job, and it can be almost in any specialty. Um, to make a comparison with doctors, either DOs or MDs, we don't need to do residency. And something I will say unique is that we can move horizontally between different specialties. So it may require more training once you do the transition, but you don't have to go back to school in order to do another specialty. For me, so far, I love this profession. I think it's great. Where I come from, there is no such thing as PA. In Venezuela, it's either you're a PA, you're a doctor, or you're a nurse. So it's hard to understand, and I understand how difficult it can be to make that distinction, that we can do all these things, but we're not a doctor. But I'm glad that I learned about this profession, and I have taken this route, and I'm here so far. Okay, now that we're transitioning from the introduction part to uh, more informational side, we're going to talk about what depression, anxiety is, and the therapy. It's important to understand that all the information presented does not substitute adequate assessment and recommendations provided by a medical professional. It's important to consult your medical provider before starting any therapy, or even considering that you may have one of these conditions. Okay, so now I'm going to give a little background on depression and anxiety, which are the two um, conditions that we're going to basically focus on before we get into the CBT. So, depression, or major depressive disorder, is a common and serious mental health illness that negatively affect how you feel, think, and act. Um, Depression causes feeling of sadness and or loss of interest in activities once enjoyed. It can lead to a broad range of emotional and physical problems, causing decreased ability to function at work and at home. In the US, depression ranks second among all diseases and injuries as a cause of disability. That's basically the summarized version of depression. However, the Diagnostic and Statistical Manual of Mental Disorder 5th edition, or DSM-5, is a book created by the American Psychiatric Association to define and establish the criteria required to be able to diagnose every mental health condition. In this case, for depression, it states that it can be diagnosed in patients with the history of at least one major depressive episode and no history of mania or hypomania. The depressive episode cannot be explained by any other medication or any other medical conditions, and the episode must last at least 2 weeks with 5 or more of the following symptoms. Some of the symptoms, like depressed mood and hedonia, which means that you're not enjoying to do activities that you once enjoyed, low energy, insomnia, or hypersomnia, which is you cannot sleep or you're sleeping too much, you feel guilty, it's hard for you to concentrate, uh, and at least one of the symptoms must be depressed mood or anhedonia. How can we diagnose depression? Well, depression, just like the majority of mental illnesses, is difficult to diagnose. Many times it is hard for patients to recognize their symptoms and the need for help, especially when the symptoms are mild. Once the symptoms are recognized, there is no test that can give you a positive result and confirm the suspicion, like any other medical illness where you have symptoms, you have concern, you get evaluated by a professional, a provider, and they can come up with diagnosis and confirm the diagnosis with the special test. Okay, so here for mental illnesses and depression, in this case, we use scales. Scales are used to somehow quantify the symptoms and stratify the severity of the condition. Also, it allows the clinician to monitor for improvement or deterioration to ensure proper therapy is being used. So scales are used at the beginning uh, to get a baseline, and then it is used throughout the therapy to make sure the patient is improving and symptoms are getting better. There are multiple scales available. There are some that are used more for screening, and there are others that are used more for diagnosis and to monitor the symptoms. We also have scales that are completed by the patient, and these are called self-reported scales, and there are also some scales that must be completed by a clinician. So the first scale that we're going to talk about is the Patient Health Questionnaire tool, which is often used as a first screen tool. It is a self-reported questionnaire consisting of 2 broad questions. Each question ranges from 0 to 3, as you can see in the picture. 3 being that these symptoms of little interest and feeling down, depressed are present nearly every day for the past 2 weeks, and 0 is that these symptoms are not present at all in the past 2 weeks. So for this scale, getting 3 or more will indicate a positive screen. Therefore, it will require further evaluation and to move on to the next scale. Remember, this is a screening test only. This is not a diagnostic test. So the next scale to do if the PHQ-2 is positive is the Patient Health Questionnaire 9 or PHQ-9. The difference between the 2 and 9 is just the amount of questions it has. The PHQ-9 is considered a more accurate screening tool for depression. So to compare, the PHQ-2 has a sensitivity of 76% and an 87% specificity, while PHQ-9 has 87 and 85% respectively. The PHQ-9 is used as a more accurate way to screen for depression as well as monitor symptoms during treatment. So the PHQ-9 consists of 9 questions, which each question has a range from 0 to 3, and maximum score is 27. A score less than 4 indicates none to minimal depression. A score between 5 and 9 indicates mild depression. A score from 10 to 14 indicates moderate depression. Between 15 and 19 indicates moderately to severe depression, and scores over 20 indicates severe depression. These 2 scales, the PHQ-2 and PHQ-9, are widely used because of their effectiveness as well as its simplicity to use, since both are self-reported screens. Okay, so now we're going to move from the self-reported scale, which are the PHQ, to the Hamilton Depression Rating Scale, which is one that must be administered by a clinician. It is also often used to rate the severity of the depression as well as to monitor for symptom improvement. A score below a 7 represents remission or minimal to non-depression. Between 7 and 17 represents mild depression. A score between 18 and 24 represents moderate depression, and a score above 25 is consistent with severe depression. So now we know how to identify and diagnose depression. It is important to know how to manage it. Treatment of depression can be broken down into 2, psychotherapy and pharmacotherapy. Research has shown effectiveness with monotherapy, meaning that you can either do psychotherapy by itself or pharmacotherapy by itself, and they both have relatively similar results when used one of the therapy by itself. However, research has shown that using a combination is better than using either therapy alone. Some people may prefer only to one of the two. Many people prefer to do pharmacotherapy by itself just because if it's more accessible, less time consuming to take a medication daily and don't have to spend any time in therapy. And then other people prefer to do pharmacotherapy by itself because they're concerned about any side effects that the medications may have. So for pharmacotherapy or medications, there are multiple drug classes that can be used. The most common one and the initial therapy usually is selective serotonin reuptake inhibitors or SSRI. Then an alternative or second line is serotonin norepinephrine reuptake inhibitor or SNRI. Other options include atypical antidepressants, serotonin modulators, tricyclic antidepressants, and monoamine oxidase inhibitors. For psychotherapy, there are also multiple methods available to treat depression. Cognitive behavioral therapy, CBT, which is the one that we're going to further discuss later in the lecture, interpersonal psychotherapy, behavioral activation, family and couples therapy, problem-solving therapy, psychodynamic therapy, and supportive psychotherapy. There are no differences in superiority among the different therapies, but the most studied and usually selected as initial treatment is CBT. Now we're going to talk about anxiety. What is anxiety? Generalized anxiety disorder, or GAD, is characterized by excessive and constant worry that is difficult to control, causing distress or impairment. For GAD to be diagnosed, this feeling of worry must occur more days than not for at least 6 months. This condition can also cause psychological symptoms such as apprehension or irritability. It can also cause somatic or physical symptoms such as increased fatigue or muscle tension. Anxiety can also cause comorbid conditions like depression. How to diagnose anxiety? We can diagnose anxiety in a similar way than depression. We take into consideration the clinical presentation of the patient and we use scales to quantify the symptoms. And like I've said before, it allows the clinician to monitor symptoms throughout the therapy. By doing the scales at the beginning, we set the baseline and then we continue to monitor these symptoms using the same scales. The most common scales used for anxiety are the GAD-7 and Hamilton Anxiety Rating Scale. GAD-7 is a self-reported scale consisting of 7 questions with a maximum score of 21. Similar to a PHQs, each can be answered within a range of 0 to 3, 0 meaning the symptoms are not present at all, and 3 meaning the symptoms listed are present most of the days. The GAD-7 is scored out of 21, with 0 to 4 representing minimal or no anxiety, 5 to 9 points represents mild anxiety, 10 to 14 represents moderate anxiety, and 15 to 21 represents severe anxiety. The Hamilton Anxiety Rating Scale, or HAM-A, is a scale that must be completed by a clinician. For this one, the range is from 0 to 4. 0 means it's not present at all, the symptoms, and 4 indicates that the symptoms are present and they're very severe. It is scored out of 56, where less than 17 indicates mild severity, 18 to 24 indicates moderate severity, and 24 and over indicates severe anxiety. The treatment for GAD will be directed by the degree of the impairment caused by this condition. Patients with mild anxiety may be able to continue without treatment, but will be recommended to have close follow-up to detect any deterioration of symptoms early. For those with indication for therapy, a combination of pharmacotherapy and psychotherapy will be superior than any of the two therapies by itself. However, this option may not always be the best initial treatment. Initial therapy has to be decided individually to tailor the needs of the patient. For example, for someone with significant social impairment, using medication can potentially yield better results than starting with group therapy. Or if the patient is more concerned for the side effects of the medications, then psychotherapy will be a better initial treatment. Similar to depression, for GAD, the preferred pharmacotherapy are SSRIs and SNRIs. Likewise, for psychotherapy, CBT is the first option to treat GAD. Now we are going to transition to the focus of the lecture, which is how we can use CBT as a preventive method for mental health disorder in adolescents. Cognitive behavioral therapy, or CBT, is a form of psychotherapy structure based on an individualized goal. It has been demonstrated to be effective treatment for a range of psychological conditions, including depression, anxiety disorders, alcohol and drugs use problems, eating disorders, and severe mental illnesses. CBT consists of a therapist helping the patient to see things from a different perspective, using a question and answer format. By doing so, the patient becomes able to understand how thoughts affect emotions. It allows them to unlearn negative concepts and behaviors in order to adopt healthier thinking patterns and habits. Through CBT, different strategies can be implemented, such as using problem-solving skills to cope with difficult situations, learning to gain confidence in their own abilities, using role-playing to prepare for potentially problematic interaction with others, facing their fears instead of avoiding them, among other strategies that are used to change the way we think in order to affect the behavior. These strategies are based on the situation and the goal. The therapist and the patient work together to reach an understanding of the issue and develop a goal that is attainable. At the end of the day, it is important for the patient to develop tools that they can use on their daily lives and be their own therapist when the situation needs it. CBT has been extensively studied and there are research supporting its benefit as well as clinical practice. CBT has been found to be effective in improving functioning and quality of life of people that have been impaired by mental health conditions. And since this lecture is focusing on a special population such as children and adolescents, it's important to mention the support for this therapy in this demographic. So the meta-analysis effectiveness of CBT for children and adolescents with depression, a systematic review and meta-regression analysis, analyzed 31 trials regarding the effectiveness of CBT in reducing symptoms of depression. It was found moderate quality evidence that supports the use of CBT to reduce depression with long-lasting effects. Okay, so now we know that CBT is very useful and effective to treat mental health conditions, but is it also beneficial to prevent? The answer is yes. The meta-analysis School-Based Depression and Anxiety Prevention Programs for Young People analyzed 82 studies from multiple countries to assess for the effectiveness of cognitive behavioral therapy in the school setting for pre-adolescents and adolescents for depression and anxiety. It was found that CBT intervention in the school setting had a small effect on depression and anxiety prevention. These effects seen by CBT in school was impacted by multiple factors, including whether the facilitator was school staff or external personnel, whether the therapy was targeted or universal, and age of participants. It was noted for both anxiety and depression. Targeted delivery had a bigger impact than universal delivery. Also, for both, the impact was larger if the session was provided by an external staff member. This means that it was done by a therapist that uh, it wasn't someone that worked in the school, such as teacher or coordinators. Um, and the age of the participant also impacted the results. And for both depression and anxiety, the impact was more significant if the participant was younger, which in these studies um, used between the age of 10 to 14. Nevertheless, the effects were noted to be maintained at the 12-month follow-up. This meta-analysis did not assess fidelity to the program or parent involvement, which both can also affect the effectiveness of the intervention. Also, the results were based on the symptoms reported by participants. In addition, since this lecture is focusing on helping the adolescent, it is also important to think of ways that would be more appealing to this group. By doing so, it allows the intervention to possibly have a better chance of completion as well as a better result. I studied prevention of depression and anxiety in subclinical adolescent, effects of a transdiagnostic internet-delivered CBT program, which focus on the impact of internet-delivered CBT on symptoms of anxiety and depression. It was found that the symptoms of self-reporting anxiety and depression, clinician-rated symptom severity, and pattern-reported severity were improved post-treatment and at a follow-up 3 months after. This method showed very good potential. Nonetheless, this study consisted of a small sample size and a follow-up of only 3 months, so we cannot assess whether the effects last as long as other methods. For this method to be more recommended, it will need further testing, but it is a good option to take into consideration as an alternative or as an adjunct therapy to CBT. So in this table we can see how many studies were compared and what the median hedges G was, which tell us how much one group differs from another, usually a difference between experimental group and a control group. We can see the difference between the overall studies and the subset that is applies to the US only. For depression, we see that the median was about the same for the overall studies and the US subset, which 0.25 means there is a small effect, same as with a US subset. However, for the anxiety, we see a very small effect size on the overall, but when we see the median for the US subset, it goes into the mother effect. But we have to take into consideration the very small number of studies used for the US subset regarding anxiety. Here with this table we see a more detailed comparisons between different variables. So for the first part we see that there is better results when the therapy is delivered by external mental health professional, which means a mental health professional or researcher. And we see the same for both the oral studies and the US subset of the studies. Then we see on the overall, we see a bigger effect in child's less than 10 years old, and then second best is over 14-year-old, which we don't have anything to compare for the US subset, but it maintains the same pattern when you compare it to the US subset. And then with the set number of sessions, we see that 2 to 7 sessions and 13 to 24 sessions has the bigger changes, the bigger difference between the control group and the experimental. Here now this we see the stratified analysis for the anxiety, and we see similar patterns than with depression. We see a better results when the therapy is being delivered by external personnel. We see better results for kids between 10 to 14 in the overall results, but for the US subset we see better results for kids over 14 years old. However, for both 10 to 14 and over 14, there's only one study to compare. And for the number of sessions, we see that 8 to 12 sessions had the biggest difference. It's better results. So why is it important to implement a therapy or a system that can prevent future mental health condition in adolescents? According to the National Institute of Mental Health, or NIHM, in 2020 an estimated 4.1 million adolescents aged from 12 to 17, or 17% of the population of this population said in the United States had at least one major depressive episode. The prevalence of major depressive episodes was higher among females than males of this age group. Out of these 4.1 million adolescents, 2.9 million had an episode with severe impairment in 2020. Also, this statistic may not include subclinical cases that can evolve into major depressive disorder in the short term. Also, this is not including people that did not recognize their symptoms and did not seek help. Only 41.6% of the adolescents with major depressive episode received treatment during the same year. According to the National Alliance of Mental Illness, depression and anxiety disorder cost the global economy $1 trillion in lost productivity each year, and depression is a leading cause of disability worldwide. Also, the World Health Organization estimates that 3.6% of kids from 10 to 14 years old and 4.6% of 15 to 19 year old experience an anxiety disorder. Also, these conditions can lead to fatal consequences. Depression can lead, or even anxiety with comorbid depression can lead to suicide in adolescents. So how can we accomplish this plan? How can we make it a reality? So it's important to consider when creating a plan or a program targeted for kids in school setting to consider different aspects of the program. It is important for the system to be engaging, to know the amount of session required to help without affecting the time invested in schoolwork and what will happen when they go on vacations. Also, creating a follow-up plan if necessary to give the best chance for these kids. There has to be a way for participants to ask for further help if required, and ensuring their privacy. These programs should be oriented to prevent future events, but also to help them recognize the need for assistance. So how many sessions do we need to have an impact and a significant result with these sessions? Based on the study dose response effects of cognitive behavioral therapy in a school mental health program, an average of 14 sessions of CBT were enough to cause significant improvement of symptoms of mental health. Although this study implemented CBT as a school but in an individualized system, it helps to create a guideline of amount of sessions necessary to cause an impact. Using 14 sessions as our baseline, we can say that we can implement 14 sessions throughout a school year, which is approximately 36 weeks of school. This will allow each participant to have one session every 3 weeks, whether it is a group setting or individualized delivery. Once more research is available to further assess therapy success, there is enough room for adjustment, whether they have to have more in 1 week or less amount of therapies throughout the year. Like I mentioned before, the results are seen better, or the results are better when a professional guides the session for better results. So another factor that may interfere or may affect the success of this program is the fact that kids go on vacation for about 2 months every year. So in the meta-analysis effectiveness of CBT for children and adolescents with depression, a systematic review and meta-regression analysis, it was demonstrated that the benefits of CBT are seen even months after treatment, which can allow participants in the school setting to have a vacation and continue during the following year without losing the work done up to that point. However, if it's needed, an alternative that can be taken into consideration for better follow-up and continuation of the program during the vacation time, it can be the internet delivery method previously mentioned. And to support this internet delivery method, and in the search for youth appealing interventions in New Zealand, it was implemented a game-like system that served as CBT for the youth. Sparks, which stands for Smart, Positive, Active, Realistic, X-Factor Thoughts, is an online program designed to treat adolescents' depression. In New Zealand, this service has been implemented for several years now, with good evidence of efficacy. Nevertheless, it shows some challenges regarding adherence due to being self-administered. There is no supervision, there is no professional supervision when the kid or participant is doing this intervention or playing this game, if you want to call it like that. It is a tool that can be used as an adjunct therapy when needed, although it has shown efficacy by itself. At this point, we know what depression and anxiety is, we know symptoms and how to diagnose, we know how to manage it, we know CBT works to treat and prevent such conditions. What if I think I may be depressed or anxious? Well, it is important to provide resources to help with those concerns. Like I said before, nothing substitutes adequate evaluation, diagnosis, and treatment by a medical provider. But there are tools available that can help participants further assess the need for help. There are multiple online quizzes that children can use in private to better understand if they're experiencing depression or anxiety, or neither, and to be able to seek help. Self-administered quizzes, I repeat, may not be used as a definitive diagnosis tool or for treatment purposes unless it is done under professional supervision. For further help, the National Institute of Mental Health have a website with different contacts to seek help, including 911 and suicide hotline. Mental Health America provides a quick summary of things to look for on others that can represent a mental health condition. It is important to be able to recognize the symptoms on others in order to help them as well. So remember, if you have a medical emergency, call 911, and if you're experiencing suicide thoughts or you know someone that may be having one of these episodes, there is a suicide hotline which you can dial 988. So now I will ask a huge favor. Please go to the link on the screen, or I will also put it on the description, and complete the questions in the survey. This will allow me to get feedback regarding the presentation, but also data regarding that will contribute to the discussion of implementing CBT in the school setting as a preventive method for mental health disorders in adolescents. And that's it. Thank you so much for listening. Thank you for participating, and I hope I was able to contribute to a healthier community. I hope that this opens a discussion for better uh, mental health system and more preventative methods, um, especially in the youth. And thank you again.